Thanks for joining us. I'm your host, Raquel Faria. I am a doctor in internal medicine at the Centro Hospitalar Universitário de Santo António in Porto. Today, I will be discussing the ACR 2023 Congress highlights with Professors Richard Furie and David Isenberg from the Lupus Academy Steering Committee. Richard, David, welcome, and thank you so much for joining us today.
Thank you, Raquel.
You're welcome.
First of all, I would like to ask you what is your global opinion on this year ACR, the 2023 Congress? Richard.
Well, first of all, it was great to return to a traditional format, real posters. And for me, it was quite nostalgic because I chaired the ACR meeting in San Diego 18 years ago. In fact, I got a big kick out of seeing that some of the sessions that we inserted into the meeting 18 years ago, like the Great Debate and the Thieves Market and the Year in Review, have survived. And of course, you can't beat San Diego for a venue.
David, what is your...
No, I absolutely agree with that. The year before in Philadelphia, it was cold, wet, and miserable. And certainly if you come from London in November, the fact that you're seeing a temperature around, in Fahrenheit terms, about 80 degrees, in centigrade terms, about 27 degrees, with blue sky. And as Leonard Cohen once put it, the sun poured down like honey. And I thought it was great. I thoroughly enjoyed it.
So for this first part of discussion, in a research highlights for drugs that are not yet approved for SLE and all of the clinical management research drugs, what was presented during this year's meeting that stood out most for you, David?
Well, I think the good news is for many years I have been saying when I give lectures how tragic it is that the biologic treatments for lupus are at least a decade, or you feel like that, behind the treatment for rheumatoid, psoriatic arthritis, and ankylosing spondylitis. And for me, as I think you and I have discussed, Raquel, I have this dichotomy in my working week. On a Friday afternoon, I do a general arthritis clinic. I see patients with respiratory diseases, and I know that if the conventional drugs that work, methotrexate, sulfasalazine, hydroxychloroquine, it doesn't really matter because I've got 5 approved biologic or small molecule ways to go, so that it's almost impossible now that you couldn't find something to help a patient. And yet on Monday morning, I go back to the same clinic room. I see lupus patients, and in the UK at least, I can use rituximab for pretty much anything. And very recently, I've been allowed to use Benlysta for almost everything. And that's it. We're not allowed to use anifrolumab for reasons of cost. Unfortunately, it's not been approved in the UK. So I just have these 2 drugs available. And yet at the ACR, there were a whole raft of very exciting possibilities coming through. We heard more about obinutuzumab. I'm sure Richard will talk about that because he led some of those studies. Deucravacitinib is looking quite interesting. There were some very interesting studies looking at upadacitinib, which was combined with elsobrutinib. As I was saying before, just as long as you could pronounce the names correctly, or you're sort of halfway there. So really some very exciting ideas that finally I think are going to bear fruit. And although it will still be clearly another 2, 3, 4 years before they become into more common clinical practice, I really came away thinking, yeah, I think there is an end in sight here. There is a better way to go, and hopefully we will be there before too long.
Thank you. Richard, do you have any particular trial that stood out for you?
Yeah, I like the upadacitinib and elsobrutinib stuff. So as David knows, we have not fared so well with BTK inhibitors in lupus.
Yes.
So both fenebrutinib and evobrutinib failed in SLE trials. But when a trial fails in lupus, you never know whether it's the drug, the design, the investigators, and so forth. But here we compared a combination of a BTK inhibitor and upadacitinib, a JAK1 inhibitor, to upadacitinib alone. And so both were clearly better than placebo. The effect size, as I recall, was around 15 to 20 percentage points. And one group had about a 5 percentage point edge with the SRI, whereas the other treatment had a 5 percentage point edge with the BICLA. So it gets to, a discussion about endpoints. But my understanding is that they are moving ahead with upadacitinib alone because it really didn't seem that the addition of a BTK inhibitor was adding much in the way of efficacy. And I think that same thing happened in rheumatoid arthritis.
Yes, and David, regarding this, do you think this is going to be promising, taking into account that the baricitinib trials didn't go through?
Well, yes, of course. The baricitinib trials, as with several other trials, if you just looked at the serological data, some of that was quite encouraging. It's almost as if there's a kind of threshold, and a number of these drugs don't quite make it over the threshold. And we saw that, for example, with atacicept in some of its first trials, although that drug was beset with other problems. But nevertheless, in the first study of flare prevention, there were some very dramatic falls in DNA binding, dramatic improvements in C3, but it didn't get over the threshold to become a successful drug. And we've seen that with various other drugs too. So this one looks moderately encouraging, I would say. One has to be cautious with lupus drugs, but there was enough there to certainly keep people's interest alive, and we hope they'll go through to the bigger trials, which will be needed to convince people.
Yes, and actually the drug of upadacitinib is the double dose, the dose that is being used is a double dose of the rheumatoid arthritis, and with baricitinib it didn't happen. Richard, do you have anything to add on these? There was an abstract also that highlighted immunomodulatory effects. Do you think this could be different from what we knew on the check inhibitors, or let's just see?
Yeah, I'm probably not the best qualified one to answer that question, but it's kind of interesting. As I recall, the upadacitinib increased naive and memory B cells. And if anything, what we're trying to do is at least knock down these B cells. So, why they went up, I don't know. But they did see reductions in the plasmablasts and the plasma cells. So yet another target that we are currently targeting with various antibodies and other techniques, which we'll talk about in a little bit.
There was another trial, the phase 2 CAT trial, where, let's see if I'm going to pronounce it correctly, cenerimod, in patients with SLE with high interferon gene expression, that it seems to have been a response in this phase 2, clinical response in alopecia and arthritis, and in those patients with high interferon expression. Richard, do you have any critical insight of the study?
I do. I have a lot. So just for some background for the people listening. So cenerimod is a sphingosine 1-phosphate 1 receptor modulator, so an S1P1 receptor modulator. And drugs like this are approved for other diseases like multiple sclerosis and ulcerative colitis. So this study, this phase 2 study, was actually presented at ACR last year, and it failed to achieve its endpoint. But a subgroup analysis was reported on this year, focusing on those with an interferon gene signature or DNA antibody. So basically selecting patients with truly active disease. Now, they did see benefit. But I guess what bothered me is they seemed to push 2 SLEDAI domains, or 2 SLEDAI items. And that was the effects on joints and alopecia. And we have problems with some of the SLEDAI items. So I think the biggest problem is alopecia, followed by oral ulcers. And actually talking about some old studies like tabalumab, we did a post hoc analysis looking at the percentage of patients who entered the studies with alopecia, oral ulcers, I think serositis was included there, and maybe arthritis. I don't remember for sure if arthritis is in there. But there are certain SLEDAI items that have a potential to adversely affect study results. And they're the ones that I just mentioned. Because alopecia and oral ulcers are worth 2 points on the SLEDAI, and they're often checked off in order for patients to achieve the needed SLEDAI entry threshold of 6 points. But these items yield very high placebo response rates. So in fact, in some protocols, we don't allow patients to have these items count towards entry SLEDAI. And arthritis presents yet another challenge because lupus arthritis is pretty subtle, or can be very subtle, and minor improvements can result in a loss of 4 points on the SLEDAI and convert a patient from the SRI non-response group to a responder. So when one puts a lot of emphasis on alopecia responses, and for that matter, arthritis responses, I am a lot skeptical. So, I mean, time will tell if they move into phase 3, which is my understanding that they will.
David, do you have anything to add on?
About that, not really. I absolutely endorse everything Rich has just said. The proof of the pudding will be in the phase 3 trial, where things ought, by virtue of being larger numbers, hopefully a little bit stricter in terms of how patients get into this study. The truth will out, as they say. But did you want us to talk about CAR T cells, or you were going to come to that later? Because that seemed to be pretty exciting.
You can talk about CAR T cells if you want now.
We thought you'd never ask. So last year at the ACR, I had a very enjoyable chance to chat to George Shett as part of the ACR meeting itself with Karen Kostenbader, and it was extremely interesting. George, some of the listeners will know, is a very lovely guy, and he has a nice sense of humor. And he said to me very seriously, well, of course, CAR T-cell therapy is really expensive B-cell depletion, which I thought was one way of putting it. But the results are very intriguing. And this year he had a talk in which he described how he had got into this sort of field and treated one patient who was very, very hard to treat. She'd not responded to anything that he had available, the conventional immunosuppressive therapy. I'm not sure whether this particular patient had rituximab, though I know it's harder to get hold of in Germany. But this was a patient pretty sick, and he was able, I think he's friendly with his local oncologist, to apply this form of treatment, which has been introduced and is widely used in oncology for the past decade, actually, to a lupus patient. And staggeringly, and it really was staggering, after 12 weeks, this patient has normal DNA binding, normal C3. They've been grossly abnormal. He made an interesting decision to me to stop all treatment, all lupus treatment, including hydroxychloroquine. And he followed the patient up for another 3 years. The patient has remained well off all treatment. Biomarkers have been normal. And for me, what was fascinating this time was he went into some detail and explained that the good B-cell responses, the responses that you need against tetanus toxoid and measles or the rest of it, those were maintained. So there really seemed to have been a major resetting of the immune system, keeping, if you like, the good guys and getting rid of the bad guys. So then they went on to treat another 7 lupus patients with equally good results. There's one patient, I think, who had a modest cytokine release syndrome, but it wasn't too bad, and he treated that with tocilizumab, I think it was. Then he went on to explain how they've also treated, I think it's 3 myositis patients and 4 scleroderma patients. The myositis patients also responded pretty well, drops in the CK, improvements in clinical features. Scleroderma patients, very interesting, clearly not the sort of benefit. And fascinatingly, that the antibodies associated with scleroderma, anti-LCL70, etc., as I understand it, did not improve, which I thought was absolutely fascinating. So that was intriguing. And you and Rich, I'm sure, like we, have been almost inundated by companies desperate to sort of get into this field. So I do think this is going to be quite a growth area. Clearly, it won't be for everybody because it's very expensive. Patients in Germany were in hospital for 2 weeks having the preparation to have their engineered T cells back again with the cyclophosphamide and fludarabine. This is not easy treatments, but nevertheless potentially very, very exciting, I think.
Yes. And probably it's going to be a strategy that we won't have any RCTs to prove it, but we'll be more and more sure of the experience.
The ideal one, which I suspect will never be done, is the patient who has the cyclophosphamide and the fludarabine and some kind of dummy procedure against the patient who has the cyclophosphamide, the fludarabine, and the engineered T cells. But I would be amazed if that ever took place.
Even ethically. Moving on.
I'm going to play devil's advocate.
Okay.
Yes, we are involved with CAR T programs here. We've treated 1 patient so far, and it is an ordeal. No question about that. But speaking of another abstract, and that's ianalumab, Also speaking about difficult drugs to pronounce. So it's a very interesting antibody, and it has a dual mechanism of action. So it binds the BLyS or BAFF receptor, so it inhibits the BLyS-APRIL pathway, but it also is a potent depleter of B cells. So there was a small study presented, 2 treatment groups, 30 patients in each of the treatment arms, basically placebo plus standard of care versus ianalumab plus standard of care. The drug is given every month, I believe, subcutaneously, and they saw an effect size of about 40 percentage points. So that's pretty amazing for a lupus drug. And the drug has advanced to phase 3 in both lupus and SLE and in lupus nephritis. So the real question, so right now CAR T companies are battling each other. You know, it's hard to get through the day without getting an email. Will you participate in our autologous program, our allogeneic program, or some other program? But I think the real battle going forward will be between potent B-cell depleting antibodies. So that could be obinutuzumab or ianalumab. And there's yet another class called BiTEs. So these are bispecific T-cell engagers. So they're bispecific in that one arm of the antibody binds CD3, so activates the T-cell, and the other arm, for example, binds CD20. So it introduces the activated T-cell to the B-cell, and you get direct B-cell killing. So it would be a lot easier, obviously, to give a monoclonal antibody over about 4 hours than the CAR T. But, you know, time will tell. And it's very unclear what the regulatory pathway forward is for CAR T.
Rich, are you persuaded, Rich, by the notion that the CAR T cells, the therapy might be more effective because it reaches into the tissues in a way that rituximab and presumably also obinutuzumab cannot do? Do you think that's an explanation for this long-lived response that George Shett has reported?
Yeah, well, I think that's a possibility, and that's why these bispecific T-cell engagers might be very appealing, because they're not dependent upon antibody-dependent cytotoxicity. They just directly kill. They introduce that T-cell to the B-cell. So tissue-resident B-cells may be far more susceptible to a BiTE than to a drug like obinutuzumab or perhaps ianalumab. But the other thing is that when our lupus trials end, they end. There's no long-term follow-up.
Yes.
We give a lot of obinutuzumab off-label. We've given about 130 doses, mostly to lupus nephritis patients. And we're right now collecting data, but I can give you anecdotes about some of my patients who were in the Nobility, you know, the obinutuzumab lupus nephritis trial 5-6 years ago, who are now in a drug-free remission.
Okay.
So we'll see how this all turns out. But I think it speaks to B-cell depletion as a terrific strategy. And David, you were involved from the get-go with that. And I remember the advisory board meetings to design the LUNAR and EXPLORER trials. We were scared to death, you know, 20 years ago about B-cell depletion. We thought all these patients would get infections.
Can I ask you something? And I think it comes with the same idea. We are now having more drugs, and we have the sense that like B-cell depletion plus acts in more severe refractory patient. And probably the small molecules would be very useful and quite safe, as the deucravacitinib. We can talk about it in a minute. So do you think we are in a place where we are having more and more data to support like a stratifying strategy in the future? Some molecules are very good to moderate to light severe, but moderate the lupus activity in patients. And some other molecules are like they're going to reset it. Do you think we are at this place, or we are far from that?
Could I make a slightly more general point, and I'll try to address that specifically? So it always struck me, even as a medical student, that when you went to the oncology wards, the oncologists were not the least bit worried about giving 2, 3, 4 drugs at pretty much the same time. And yet when you went back to the rheumatology wards, we were little pussycats. We would give methotrexate, let's say for rheumatoid for 3 months on its own. If it worked, that was fine. If it didn't work, we would stop it. We'd move on to something else, one drug. It was one drug, one drug, one drug. And then it was really only in the last 25, 30 years that the notion that you could give 2 or 3 drugs in rheumatology began to sort of seep into the consciousness. And I suspect, since it's certainly true in oncology, that they again are using several monoclonals at the same time without without thinking twice about it. And yet we in rheumatology haven't really done that. There have now been 3 trials, as you know, combining rituximab and Benlysta, admittedly with mixed results, but certainly the Beat Lupus trial looked very encouraging. And it may be that the way that it was given in that trial, where everybody got the rituximab and then half of them got the Benlysta, and they did much better in terms of reducing clinical flares, where we saw just 3 compared to the guys who just had rituximab and placebo, where there were 10 flares. That was very significant. So it may be that, yes, the idea of combining biologics is something which we ought to be moving towards. The challenge will be to find the right combination. And that's not going to be absolutely straightforward. But yes, what you said, I think, makes some sense. And I wouldn't be at all surprised if in 20 years' time, we're using 2 or 3 monoclonals without thinking twice about it in lupus as well.
Richard, do you have any particular insight of this kind of, we are going to have drugs for moderate and other drugs for severe?
Well, I have mixed feelings about this. So maybe lessons learned from rheumatoid arthritis. So when I was a fellow and junior faculty, we used to talk about the pyramid. Do you remember the pyramid for rheumatoid arthritis? Start low and go slow and build it up. And by the time you built it up, the patient had a lot of damaged joints. So take lupus nephritis, for example. We do a terrible job with lupus nephritis. Most of our patients don't achieve a clinical, a complete remission. So maybe right off the bat, we should be super, super aggressive. So invert the pyramid and see if we can really reset the immune system. So besides George Schett's cohort, there are obviously many companies just getting started, but there's a group actually on Long Island, but they're doing their studies in China that are studying a bispecific CAR T. So it targets BCMA and CD19. So you're knocking out plasma cells, B cells, and the 12 patients that they've treated have also undergone a remission. So maybe for certain populations, we need to be very aggressive early on. But then the question is, where do you draw the line? What is the threshold for being moderately aggressive versus super aggressive? And that's what we need to figure out.
And taking that in account, I've selected also another abstract to discuss from a drug which is not approved for lupus, but it can be, we're almost there to be approved for other diseases. So deucravacitinib. We have learned from the trials from deucravacitinib, and now there was an abstract with patient-reported outcomes, which was quite significant in pain, fatigue, overall health-related quality of life. Richard, what do you think of deucravacitinib safety versus JAK inhibitors? It looks like it's more safe, but do you have any additional insights on the difference between them?
Well, before even discussing deucravacitinib, I'm not sure that we saw any safety signals with baricitinib. So
yes, yes.
We've not seen a thrombosis signal with baricitinib or deucravacitinib, nor am I aware of a cardiovascular signal.
Okay, so there's more of a discussion coming from other areas that worries us, and we should just look at the data. The part 2 of this discussion, we are going to just highlight some things about new data on treatment strategies that are already being used and drugs that are available. And actually, when I just tried to look in the abstracts book, there were more than 100 abstracts where about the use of belimumab experience all over the world. And it's amazing. And there was one that kept my attention. That is the comparative risk of serious psychiatric events with belimumab versus the oral immunosuppressants that we use classically, and what were the serious psychiatric events from one arm and the other in lupus. Richard, can you please comment on that?
Sure. Well, there's a whole story there, and it goes back to November 16th, 2010. So what was special about that day? That was the day of the FDA Advisory Committee meeting for belimumab. And there were a lot of issues that arose. One was about the response rates in African Americans, but the other was about suicidality. And one of the reasons that arose, there was someone on the FDA Advisory Committee, a pulmonologist, as I recall, who was very sensitive to this because there was a drug for pulmonary use that was presented to the FDA a couple of months prior, where there was also this issue of suicidality. So it was kind of fresh in her mind. Anyway, so if you look at the phase 3 belimumab studies, and there were a lot of patients in those studies, there were, I think, over 1,600 between BLISS 52 and BLISS 76. Anyway, there were 2 suicides in the belimumab group, I think one like within the first 6 weeks and another later on. And so that created a lot of issues. And so very attuned to follow-up studies and analyses. There was what was called the BASE study, which was this huge study. First author was Sarah Sheikh. 4,000 patients in that placebo-controlled trial. And they did see a depression and suicidality signal there. But if you look at other studies, there's a meta-analysis that did not show that to be the case. So April George presented the abstract that you're talking about, where they were able to get data from a United States health records database. I think it was called TriNetX. Anyway, huge numbers of lupus patients in this database, almost 100,000. And so they compared about a little over 2,000 patients who got belimumab versus about 5,600 who were on azathioprine. The next comparison, a couple thousand patients on belimumab to 7,000 patients on methotrexate, and then similar type of comparison to mycophenolate. And they use propensity score matching. And I think these epidemiology studies are very difficult to do. But the bottom line is they found no differences in the risk of hospitalized depression amongst belimumab initiators compared to azathioprine and methotrexate. And in fact, the risk of hospitalization for depression seemed to be lower for belimumab than for mycophenolate. So their conclusion was that they haven't, or at least in this analysis, did not see a signal. But again, there are mixed results, looking at this issue.
David, do you feel that that there's something that is happening with us, that the scare and the fear of suicidality with belimumab is sometimes preventing the prescription of belimumab in a patient who had previously had neuropsychiatric involvement, mainly with psychosis? So do you think we are in the way to have data that can just support a little bit more the prescriptions?
Well, I can talk to you from some personal experience about this. So in our group of patients, lupus patients, about 850 now, we published a report about a year or two ago describing the frequency with which you see neuropsychiatric disease, serious neuropsychiatric disease, with psychosis in particular, although there is elements of depression within that. Very small numbers, really. I think it's 17 or 18 out of 750 patients at that time. So this is pretty uncommon. And the good news about it was what happened to these patients long term. The vast majority of these patients have their psychosis at the start of the lupus. it takes a combination of immunosuppression, antipsychotics, and time to get these patients better. But within 6 to 12 months, virtually all of those patients had gone back to normal, and the vast majority of them, 14 out of 17, did not flare again with psychosis. So that was kind of good. So I wouldn't be too worried about a patient who'd had a psychotic episode at the start of the disease. They've been fine for 10 years. Benlysta's becoming available. I would be very happy to give such a patient Benlysta. Then what about the rate of suicide within lupus populations? So again, we've looked at this in our own group. We've seen in 850 patients 3 suicides for 3 very different reasons. One girl had a row with a boyfriend, took a large number of tablets, and died as a consequence. I think that's not hardly a lupus-specific problem. Another patient rather mysteriously committed suicide almost a year to the day after she'd had rituximab, having told her mother the day before that she was worried her lupus might be coming back, which was clearly a real shame because we would have just given her some more rituximab. And the third patient was a very remarkable patient who was an artist who felt that what lupus had taken away from her, her CNS lupus had taken away from her, was ability to think creatively. And she put it, without that element, I'm not me and I don't wish to carry on living. Those are the only 3 suicides, successful suicides, that we've seen in 40 years in 850 patients. So there's a small risk of suicide occurring in lupus patients. And we've seen, I would estimate, about 4 or 5 times as many attempts that we are aware of. Obviously, there may be some that we're not aware of. So you have to recognize that suicide and suicide attempts are a small part of lupus anyway. And I do think when you're looking at this problem, you do, as Richard just enumerated very cautiously, you have to look at large numbers of patients to get a real sense of what's going on here. And I was never really convinced by the data that Benlysta was a great cause of dramatically large numbers of suicides. I think the larger the numbers that have been looked at, the less likely that seems to be the case. So I think provided you are aware of what might be, underlined might be, a slight increase, I think the bigger problem is if you've got a disease which isn't responding to conventional drugs, you've got Benlysta, which is probably going to help you. If you've got joint skin problems, I would go ahead and do it. And obviously keep a very close watch as best you can do on the patients themselves, if you are actually worried about them.
Going on with belimumab, and David, a study that came from your UCLH group was the Beat Lupus with previously reported data. And now it was replicated in the Calibrate trial, the probably biomarker that could predict response, the IgA2 anti-dsDNA antibodies. Do you want to comment on the clinical point of view, what this could mean in the future?
So the primary endpoint in Beat Lupus was a serological endpoint, the reduction in antibodies to DNA, by which I mean specifically IgG antibodies to DNA. And that endpoint was met. And of course, just to be fair to a lot of other trials, reductions in DNA binding have been seen in a whole raft of other trials too, but that was the one we went for. But we had a remarkable guy called Mo Schipper who was helping Michael Ehrenstein to run the trial. And Mo is one of those guys who, when he gets his teeth into something, likes to really give it a good go. And he set up a huge raft of assays, including IgA antibodies to DNA. And I never quite found out why he did that, but as life has these things, so it turned out that that was the best biologic marker or biomarker to actually correlate with effect in clinical benefit in patients in the Beat Lupus trial. We then went to the Bliss Believe trial to ask them if we could have some access to their samples. And essentially, he reproduced that data, which was quite amazing to me. So we're currently trying to set up a trial in which we're going to use, we hope we can get the money, IgA antibodies to DNA as a kind of predictor, a little bit of precision medicine creeping in, and see if we could predict which patients are going to respond if they've got the sort of highest levels. But it was a big surprise. IgA is certainly not something which we measure in any sense routinely with our DNA binding assay. It's IgG specific. With our cardioligand assays, we distinguish IgG and IgM, but we don't do that with the DNA binding. And we don't measure IgA routinely, but perhaps we may have to do that.
Richard, there were several abstracts also on the anifrolumab, also on the extension studies. And one of them was on the renal outcomes from the non-renal SLE TULIP trials. Do you think we have gained a some outcomes that we could use in clinical settings from these analyses?
Yeah, so I actually presented that. So for a little background, the anifrolumab TULIP-1 and TULIP-2 studies were followed by the option for patients to enter a long-term extension. And what was very unique about the long-term extension is that it was placebo-controlled. So if you finished TULIP-1 or TULIP-2 and were on anifrolumab 300 milligrams, you could go into the extension and you would remain for the next 3 years on anifrolumab 300 milligrams. If, however, you were on placebo in TULIP-1 or TULIP-2, you were re-randomized to move to 300 milligrams of anifrolumab for 3 years or remain on placebo. So at the start of the extension study, there was about a 4-to-1 ratio of those on anifrolumab to those on placebo. But there were a lot of, it was mainly a safety analysis, but there were efficacy data generated. So I presented the renal data. And basically, two messages: that if you received anifrolumab, you were more likely to have improvement in renal parameters on the SLEDAI, and you were less likely to develop new renal parameters on SLEDAI. But what needs to be emphasized is that the percentage of patients with items checked on the SLEDAI in the renal domain were very low, it was in the single digits. So I would take this with a grain of salt. What really needs to be done is a proliferative nephritis study with anifrolumab, which actually was done in phase 2. And there were some positive results with the higher dose. And that's being performed again in phase 3. But I think more telling is translational data. So we know from the Accelerated Medicines Partnership studies, the AMP, so-called AMP, as well as other studies, that interferon is made in the kidneys. So it would make sense to try something like anifrolumab for those with active kidney disease.
And in lupus trials, David, there was some discussion points during ACR and we have a lot of lupus nephritis trials that have come in with good results, and there are steroids doses issues that have come pretty low, like with Aurora, and there are also extension to the trials have been for 2 or 3 years follow-up, so that have never been done quite similarly in lupus nephritis trials. What do you think we can learn from the new lupus nephritis trials?
Well, I'd like to suggest that there are two important things in this general area. One is the notion that you really have to mandate steroid reductions in the context of a clinical trial to maximize the chance of the drug under consideration, to give it a chance to work. So I was pleased to see that in the PACE study, that's the deucravacitinib study, there was a mandated taper to, I think, 7.5 after 20 weeks. Voclosporin was even more dramatic. That was down, I think, to 2.5 after 12 weeks. I seriously love that. I thought that was terrific because I really think that at least gives your drug a chance to shine. And if your drug doesn't work after you've dropped the steroids that low, then it probably isn't going to be any good. So I think that was important. And then, of course, lupus nephritis arguably is for life, or at least something approaching life. So I think a study which lasts for 3 months is clearly too short. 6 months is probably too short. A year is just about okay. But clearly, if you're studying these patients for 2 years or 3 years, I think the longer you can do it, the problem, of course, is that increases the cost substantially, which is why, that there haven't been that many trials of that duration. But I think the longer you can go with a clinical trial, the more, the better the better handle you're going to get on just how effective and the duration of the effect is going to be.
Richard, and there's another thing that came out in the ACR but have been discussed for the previous 2, 3, 4 years probably, is adjuvant therapy, neoadjuvant therapy to the kidney function in lupus nephritis. Do you want to highlight any abstract or comment on this?
I remain very confused about SGLT2 inhibition in lupus nephritis, or for that matter, any of our patients with kidney disease. And there have been a couple of reports, but very small studies, like 8 patients, 11 patients. But Michelle Petrie had a very interesting poster, and she and her colleagues looked at about 45 patients with lupus nephritis and examined the slope of GFR before and after starting an SGLT2 inhibitor, and also looked at proteinuria. And the bottom line is, though she saw a blunting of GFR loss on the SGLT2 inhibitor, it wasn't statistically significant. So this could just speak to the small numbers of patients, or maybe a longer period of time that needed to be followed. But the difference in slope was around 2.2. And then she did a similar analysis examining proteinuria. And like with the GFR analysis, there was a blunting in the protein creatinine ratio slope after starting the SGLT2 inhibitor. But again, statistical significance was not achieved. So I'm curious, maybe I can ask the two of you, what are you doing about SGLT2 inhibitors? I have more people not on them than on them, but I don't know how to use them.
So our nephrologist is a really wonderful colleague, and she's been going crazy about it for the last year. And every time she sees a lupus nephritis patient, she sort of, I would say, bangs her fist and put them on this SGLT2 inhibitor. And so we've started quite a few actually in the last year. We haven't really done an analysis to see if it's really made a difference. I'm aware of the fact that I think it was in the Annals there was a paper on lupus from mice. I think it was the MRL-LPL mice with lupus nephritis, which seemed to indicate some benefit. But yeah, I'm certainly not aware of any trial data yet. That hasn't been done.
In our multidisciplinary meeting, the nephrologists are all excited about the effect in non-lupus other diseases from the kidney, and it looks amazing with really good outcomes on supporting the kidney function. So we have tried in some patients, but the thing I found, and it's the patients that are on immunosuppression, as it increases the glucose on the urine. If the patients have tendency to urinary tract infections or candidias, they get more flares of the infection and candidias. So probably it won't help every lupus patients, mainly those that are more prone to have infections. But on the others, due to the kidney function, I'm waiting for more results, but I don't think it's wrong to try to do it. And finally, David, Richard, do you have any additional comments on what we've learned in ACR? Anything that we missed and you are remembering just now that you want to highlight from the meeting?
Well, from my perspective, only to say that at a meeting of the International Lupus Group, Slip Group, on the day before the main ACR meeting started, we were addressed by 3 colleagues from Africa. And it just reminded us, I'm sure, of the great disparity in healthcare that's available between countries like the States and Europe and UK, obviously, and countries in Africa, where even getting a DNA antibody test done can be quite a major undertaking, let alone a kidney biopsy. So these colleagues were coming from places like Ghana and Uganda, and you realize just how hard it is for these investigators to try to get the lupus trials or get incorporated into lupus trials. It's very, very challenging, and that was quite a sobering set of discussions that we had.
Richard, do you have anything to add?
No, just a perspective. I guess it's because I've now been doing this almost 40 years. But if you go back not that long ago to the mid-1990s, around 1995, there were just 2 drugs in development for lupus. Now there are more drugs in development than there are patients. And it's incredibly difficult to keep up with the literature. I hope this podcast helps. And not only must we keep up with the rheumatology literature, now we must keep up with the oncology literature. But I think the end result, no doubt, will be more drugs will be approved, and this means better outcomes for our patients.
Thank you so much, Richard and David. Thank you for joining me today and sharing your insights. To our listeners, we hope these discussions have helped you gain more of an understanding of lupus. Do send us feedback on cases you would like us to discuss in the future. Thank you so much for listening. We hope you enjoyed this podcast. Please leave us a review, which will really help us in reaching as many of your colleagues as possible around the world. Join us again next time.